Hello, this is Dave Rakel. Happy holidays. I just want to create a quick video just to make sure that we're communicating our intent correctly. I think the root of all evil is poor communication, so I'm going to try and over communicate when I can, as much as I can. And this is in regards to the primary care incentive. And I just wanted to explain the intent from different perspectives of this process. So let me start by just sharing this very basic process of where the how different people look at this process and why we are trying our best to meet everybody's expectations, but in the end really reward being a primary care physician who manages a panel of patients. So if we look at the payer's perspective, what they care about, are they getting value for their money? So they need access, and they want to show that we are achieving the triple aim. So we have high patient satisfaction, and we have some clinical metrics that we're following that shows that we're trying to improve care. So the two that were chosen for us to show the payers that we are working on this is diabetes and hypertension. Our UNM administration really wants the best of all worlds. They want to satisfy the payers as well as make sure that we're creating a healthy practice environment for our clinicians so they can focus more on patient engagement and less on clutter, such as looking at computers. And so how can we create these team-based care models that really remove barriers that might be in the way of human engagement? So this is what you see quarterly, and again, this is an iterative process. I think the most important thing that we can communicate is the number one priority is for us to reward primary care. You know, we've always been somewhat of a neglected stepchild in regards to financial rewards, but now I think the nation is seeing the value of primary care, and we need to start rewarding that through some of these incentives. And it is a challenge. One of my colleagues said that the hardest time they had as a chair was when they wanted to give his faculty a raise, which is interesting. I mean, that's what we're trying to do, is really reward just being a relationship-centered primary care doc who manages a panel of patients. So I think this spreadsheet's going to change over time, but just to review how we figure out these quarterly incentives. Number one, we have to do a population health learning each quarter, or you can do a one-on-one power chart learning where you just call them, they'll set up a one-on-one, and then they will credit you automatically. And when you go into Learning Central, you have to put in population health. We're trying to make it so you don't have to do this. So every time you just log into your Learning Central, the population health materials will pop up. But right now you have to type in population health and then go, and then those modules, you just have to do one of them, will pop up, and then you click that you did it, and then you will get credit for that. So I think that's an important thing to remember. This is a go, no go, because our UNM administration and population health, we need to communicate why we're doing this, and having people have insight into the strategy is really important for engagement. The next most important thing is just being in clinic. I think that's the most important thing. We just want to reward people who are in primary care clinic managing a panel of patients, and that is the majority of this reimbursement is an incentive. And the more you're in clinic, the more incentive you'll get. The baseline is 0.3, 3 half days in clinic. All those who have 50% or more RVUs will get $6 per RVU. The next two metrics are a little bit more challenging because we don't have as much control. So even though the payers want us to show quality metrics, hemoglobin A1C, blood sugar control, and blood pressure, we don't really have complete control over that. It's more of, in the ideal situation, it's a team-based process to bring blood sugar and blood pressure under control, and we have to have patient engagement. Also, same is true for patient satisfaction. Also a challenging thing, since many people who might be more disgruntled are more likely to give us that feedback, and we don't have enough numbers. So these are two areas that we're going to have to learn and do more and make them better. But the thing that won't go away, number one, is the education that we all need to do, but also just being in a primary care clinic. Just being there, improving access, providing your art to people you care about over time is always going to be there and may actually grow over time. So we had a scholar come in, Maureen Smith from University of Wisconsin. Dr. Pandey invited her, and we learned a lot about learning health systems, about how we can apply our research and our data collection into the process of care. And it made me think of this visual that constantly we're trying, we're failing, we're learning, and we're improving. And we learn from that data we collect, and we try and do it better. So this is an iterative process. I think this is going to change over time, but that's what it is now. And it's going to change because we're going to do this. So thank you for hanging in there with us, and realize that it's not going to be perfect from the beginning, but we will get better and better. And in the progress of this process, we will get to a better place together and be able to provide better care at a higher quality with more enjoyment. So I hope you all have a wonderful holiday, and make sure you take time to give those people you love most your attention.